Immune pathology. Immune system consists of the following organs. First, central organs, including thymus and bone marrow, and peripheral organs, presented by accumulations of lymphoid tissues in the nasopharynx, in lymph nodes, in appendix, and Peyer's patches. Another peripheral organ is spleen. There exist two kinds of immunity. First is congenital or innate immunity, and the second is acquired or adaptive immunity. They have common mechanisms which are presented in the picture. There exist two types of immune response. Humoral immune response, which is realized through production of antibodies, and cell-mediated immune response, realized through activity of T killer cells. Typical disorders of immunoreactivity. They are immunodeficiency, pathological tolerance, transplant against host reaction, allergy, and autoimmunity. Let us, in brief, look at these disorders. Immunodeficiency is a typical form of pathology characterized by reduced effectiveness or by complete inability of the immune system to detect, destruct, and eliminate foreign antigens. Kinds of immunodeficiency are by predominating damage to immune cells. They are A cell dependent, B cell dependent, T cell dependent, and combined. By origin, immunodeficiency may be primary, genetically determined, and secondary. By time of development in the ontogenesis, immunodeficiency may be antenatal, postnatal, and perinatal. In the table, you see comparative characteristics of primary and secondary immunodeficiency. Primary immunodeficiency is genetically determined, and secondary is acquired. Primary immunodeficiencies are presented by syndromes with deficit of antibodies, by syndromes with deficit of T lymphocytes, by combined deficits of T and B lymphocytes, by syndromes with deficit of complement components, by syndromes with defects of phagocytes, and by syndromes with defects in natural killer cells. General features of the clinical presentation of primary immunodeficiency include infectious syndrome, frequent recurrent infections with a chronic course, delayed mental and physical development, gastrointestinal disorders, chronic diarrhea, positive family history, combination with developmental defects, hematological disorders, tumors. B-cell primary immunodeficiencies. They include a gamma globulinemia with deficit of B cells, general variable immune deficiency, a gamma globulinemia with hyperimmunoglobulin M, rare kinds of a gamma globulинemias, transient hypogamma-globulинemias of infancy, selective deficit of immunoglobulin A. An example of primary humoral immunodeficiency is X-linked gamma-globulinemia or Bruton's disease. This disease is associated with a pathological gene BTK, which codes for Bruton's tyrosine kinase. It is characterized by failure of pre-B cells to differentiate into B cells. In this disease, B cells and plasma cells are absent or decreased in the circulation, and serum level of all classes of immunoglobulins are depressed. Germinal centers of lymph nodes, Peyer's patches, the appendix, and tonsils are underdeveloped or rudimentary. T cells and cell-mediated reactions are entirely normal. Clinical manifestations include repeated purulent infections manifested after 6 months age, such as bronchopulmonary diseases and infections of ear, nose, throat organs. By hypoplasia of palatine tonsils and of peripheral lymph nodes. Treatment consists in antimicrobial chemotherapy, substitution therapy, which are intravenous infusions of preparations of donor's serum immunoglobulin every 3 to 4 weeks. T-cell dependent primary immunodeficiency. They are characterized by early onset, developmental delay, by development of viral and fungal infections of the skin, nails, scalp, mucous membranes of the bronchopulmonary apparatus, intestine, genitals, by prolonged diarrhea, and by malignant neoplasms. Thymic hypoplasia or DiGeorge syndrome. It is genetic defect which consists in deletion of 22nd chromosome. The disorder results from a congenital malformation affecting the 3rd and 4th pharyngeal pouches. These are structures which give rise to the thymus, parathyroid glands, and portions of the lips, ears, and aortic arch. The thymus is usually rudimentary, and T cells are deficient or absent in the circulation. Lymphopenia. In thymus-dependent zones of lymph nodes and in spleen. Infants with this defect are extremely vulnerable to viral, fungal, and protozoal infections. Susceptibility to intracellular bacteria is also increased. The B cell system and serum immunoglobulins are generally unaffected. Severe combined immunodeficiency represents a constellation of genetically distinct syndromes, all having in common variable defects in both humoral and cell-mediated immune responses. Affected infants are susceptible to recurrent, severe infections by a wide range of pathogens, such as bacteria, viruses, fungi, and protozoa. The most common form, accounting for 50 to 60% of cases, is X-linked. Immunological disorders in this syndrome include lymphopenia due to deficit of T cells, energy of T cells and sometimes of natural killer cells, sharp reduction in the amount of lymphocytes in the thymus, lymph nodes, spleen, lymphoid tissue of the intestine, and in peripheral blood, absence of antibody response with decreased amount of immunoglobulins and B cells in blood. Clinical manifestations appear in the first weeks or months of life and are characterized by stoppage of development and growth, by severe diarrhea, vomiting, candidiasis of skin and mucosa, progressing dyspnea, cough. The patient dies from diseases induced by opportunistic or low pathogenic microbes. Secondary immunodeficiencies. Secondary immunodeficiencies are disorders in the immune system that develop in the late postnatal period or in adulthood and are not associated with hereditary defects. Please see the table below for examples. Acquired immunodeficiency syndrome, AIDS. The cause is HIV, a human retrovirus belonging to the lentivirus family. The main clinical symptoms of AIDS arise from profound immunosuppression that primarily affects cell-mediated immunity, and it is a sure sign of AIDS. This results chiefly from a severe loss of CD4 plus T cells, as well as from impairment in the function of surviving helper T cells. HIV has a tropism to CD4 T plus T cells. In addition to loss of T helper cells, functions of monocytes and macrophages also suffer in HIV infection. In the table, you see AIDS defining opportunistic infections and neoplasms that are usually present in patients with HIV infection. Immune tolerance. Immune tolerance is a state of unresponsiveness of the immune system to substances or tissue that have the capacity to elicit an immune response in a given organism. Kinds of immune tolerance are pathological, physiological, and induced. Mechanisms of pathological tolerance include shielding of the foreign antigenic determinants by immunoglobulins, antigenic overload of the immune system with antigens, insufficient co-stimulation of T lymphocytes, apoptosis of cytotoxic T lymphocytes, activation of T and B suppressor cells, immunodeficiency conditions. Transplant against host reaction. The cause is graft immunocytes, bone marrow, spleen, blood, small intestine, liver, leukocyte mass. The reaction is promoted by the following conditions. First, genetic or antigenic foreignness of donor and recipient. Second, presence of immunocytes in the transplant. Third, inability of recipient to eliminate or reject transplant. And fourth, transplant against host reaction is characterized by damage to organs and tissues of the recipient's immune system, damages to skin, gastrointestinal tract, especially in the zone of Peyer's patches, and to the liver. Autoimmunity. Autoimmune process is immune inflammation directed against normal, unmodified antigens of self-tissues in a result of formation of autoantibodies and autoreactive lymphocytes. Autoantigens are normal proteins and other macromolecules of a human organism, or sequestered antigens, antigens of brain, islands, thyroid, colloid, testicles. They may be modified proteins formed in inflammation, mutation, tumor degeneration, such as cold-associated, burn-associated, irradiation-associated proteins, and cell plus toxin, cell plus microbe complexes. One more kind of autoantigens is cross-reacting antigens, the phenomenon called molecular mimicry. By mechanisms, there are distinguished two groups of autoimmune diseases. First group, diseases caused by changes in the immune system. Immune dependent, non-antigen dependent. Second group are diseases caused by changes outside the immune system, non-immune dependent, antigen dependent. Immune-dependent autoimmune diseases are associated with disorders in the immune systems, such as mutations in proliferating immunocytes, disorders in normal proportion between T, B suppressors and T helper cells, disorders in normal proportion, isotope and anti-isotope, cancellation of energy of T lymphocytes to self-antigens. The second kind of autoimmune diseases is non-immune dependent diseases, which are caused by the following factors: cancellation of natural tolerance to self-antigen, emergence of sequestered antigens, introduction into an organism of antigens similar to endogenous antigens, molecular mimicry, modification of molecules, modification, mutation of body cell genome. Here you see examples of autoimmune diseases. Allergy. It is a typical form of pathology of the immune system that develops, as a rule, after repeated exposure of the immune system to a foreign antigen. It is characterized by alteration, usually increase, in the sensitivity to the given antigen, and consists in detection and often, but not always, destruction and elimination of the foreign antigen, in damage to cell structures of an organism, in impairment in its adaptive characteristics, and in derangement of the vital activity. Allergens are exogenous or endogenous substances that induce allergy. There are distinguished exoallergens, exogenous allergens, and endogenous allergens. Please see the table for exogenous allergens and endogenous allergens. Kinds of hypersensitivity. In 1930, Cook distinguished two kinds of allergic reactions by the period of their development after contact with allergen. These are immediate type and delayed type hypersensitivity. Immediate type develops in less than 20-30 minutes after action of allergen. Delayed type takes more than 6 to 8 hours. Immediate type hypersensitivity is mediated by antibodies and delayed type by T lymphocytes. In immediate type hypersensitivity, desensitization is possible, and in delayed type, it is impossible. In 1963, a Soviet scientist, Ado, divided allergies into two groups depending on the pathogenesis: true allergic reactions and false allergic reactions that develop on the first contact with allergen without preceding sensitization, which means absence of immunological stage. In 1969, Gell and Kuntz proposed classification of hypersensitivity by the mechanism of immune damage. So, this classification includes 4 types of hypersensitivity. Type 1, anaphylactic reaction. Type 2 is cytotoxic type. Type 3 is immune complex type. And type 4 is cell-mediated reaction. General pathogenesis of allergic reactions includes three stages: immunological stage, pathochemical stage, and pathophysiological stage. Immunological stage starts on the first contact of an organism with allergen and includes the following processes. First, detection, processing, and presentation of allergen by A cells to lymphocytes. Second, synthesis of allergic pools of antibodies and or formation of clones of sensitized lymphocytes. Third, formation of T and B lymphocytes of immune memory. Fourth, fixation of antibodies and or of sensitized lymphocytes in tissues. Their circulation in the biological fluid. The second stage, pathochemical stage. It is a stage of biochemical reaction. It includes biosynthesis, release, activation, realization of the effects of mediators of allergen, and alterations in target tissues. Pathophysiological stage is the stage of clinical manifestations. In this stage, we see a response of cells, organs, and tissues to mediators produced in the previous stage. In this stage, we also see development of pathological processes in the target tissues and disorders in the vital activity of an organism. Now, you see type 1 hypersensitivity reactions, and you see the allergens in these reactions, which are always exogenous. We said that allergen in type 1 hypersensitivity reaction is always exogenous. On the first exposure to an allergen, antigen-presenting cells, dendrite cells or B lymphocytes, capture, process, and present the allergen in complex with class II histocompatibility molecule to T helper cells, which produce cytokines, interleukin 4 and interleukin 13, that control the immune response. Effector cells are B lymphocytes, which differentiate into plasma cells producing immunoglobulins E and G4. These antibodies are cytophilic and have high affinity to specific receptors on mast cells and basophils of blood that possess the highest capacity to bind immunoglobulins E, for which reason they are called first-order target cells. Second type of receptors to immunoglobulin E is a low-specific receptor expressed on B lymphocytes, eosinophils, macrophages, and platelets, second-order target cells. A part of B lymphocytes turn into memory cells, which provide express response to the allergen within 10 or 20 minutes in case of its repeated entry into the body. In result of formation of antigen plus antibody complex on the surface of mast cell or basophil, immunoglobulin receptors acquire enzymatic activity, which is followed by a cascade of biochemical reactions. Mediators of granules, primary mediators, and mediators produced in activation of cells, secondary mediators, are released. Preformed mediators are histamine, heparin, factor of chemotaxis for eosinophils, and factor of chemotaxis for neutrophils. The source of newly formed mediators in target cells are products of lipid degradation. These mediators include slowly reacting substance of anaphylaxis, leukotrienes C4, D4, leukotriene B4, prostaglandin D2, platelet activation factor, and thromboxane A2. This picture illustrates the mechanism of pathochemical stage of type 1 allergic reaction, which consists in degranulation and release of mediators from cells. Now, third stage. Mediators act to relax smooth muscle elements of arterioles and capillaries, which results in their dilatation, hyperemia, and arterial hypotension. Increased permeability of microcirculatory vessels leads to edema. Hypersecretion of mucus and of secretions is noted. Smooth muscles of bronchi, intestine, and uterus undergo spasm. Binding of the antigen in the nasal passages causes allergic rhinitis with nasal congestion and inflammation of the tissues, whereas binding of an antigen in the gut may cause diarrhea or vomiting. There are two forms of anaphylaxis: systemic anaphylaxis, which is characterized by dramatic drop in systemic blood pressure during an anaphylactic reaction, which is called anaphylactic shock. And second is local anaphylaxis or atopy. Here you see examples of diseases based on the first type of hypersensitivity. These are urticaria, above pictures, then allergic conjunctivitis, Quincke's edema, and bronchial asthma. In second type hypersensitivity, allergens are usually components of cells. Here, A cells detects, processes, and presents an allergen to T helper cells. T helper activates B lymphocyte, which transforms into plasmacyte and begins to produce antibodies, immunoglobulins G and M. Besides, memory B cells are also produced. Antibodies attack tissue antigen with formation of antigen plus antibody complex on the surface of cell membranes. Immunoglobulins G and M possess ability to fix and activate complement, and they function as opsonins. Pathochemical stage may occur in three ways. First is complement-dependent cytolysis. Second is opsonization and phagocytosis. And third is antibody-dependent cellular cytotoxicity. Now we see complement-dependent cytolysis. Here, antigen plus antibody complexes are fixed on the cell membrane surface. They bind complement and activate it in classic pathway. Here, membrane attacking complexes are formed, consisting of complement components 5, 6, 7, 8, 9. They induce damage to cell membrane and cell lyses. Actually, this complex drills pores in the membrane through which sodium begins to enter the cell, followed by water. In result, the cell swells and its membrane ruptures. C3b complement component is opsonin. It binds with membrane receptor on the membrane of antigen with one end of the molecule, and with the other end it binds with the receptor on the membrane of phagocyte. So in this way facilitates capture and engulfment of antigen by phagocyte. Antibody-dependent cellular cytotoxicity. It is realized through attachment of killer cells to Fc fragment of immunoglobulin G and immunoglobulin M antibodies, covering target cells with their subsequent lysis by perforins, and through production of active metabolites of oxygen, for example, superoxide anion radicals. So antibodies serve as sort of bridges between target cell and effector cells. Effector cells are granulocytes, macrophages, platelets, natural killer cells, lymphoid tissue cells without characteristic markers of T and B cells. Antibodies may not only cause death of antigen cell, but they may also stimulate its function, the phenomenon called antibody-mediated cellular dysfunction. In the screen on the left, you see an example of such dysfunction. Antibody against thyroid stimulating hormone receptor stimulates thyroid epithelial cell to produce thyroid hormones without thyroid stimulating hormone. In result, hyperproduction of thyroid hormone develops, and Graves' disease. To the right, you see illustration of development of myasthenia gravis. Here, antibodies are produced against acetylcholine receptors, which inhibits binding of acetylcholine to receptor with resultant block of nerve-muscle transmission. Examples of diseases that develop by second-type hypersensitivity. They are allergic hemotransfusion reactions, where antibodies of patient serum interact with antigens on the transfused erythrocytes. Autoimmune hemolytic anemia, involving antibodies produced against red blood cells. Post-transfusion neonatal idiopathic thrombocytopenias. Autoimmune leukopenias. Hemolytic disease of newborns resulting from penetration of mother's anti-rhesus antibodies across placenta with destruction of fetal erythrocytes. Goodpasture syndrome, formation of antibodies to basement membrane of glomerular and alveolar capillaries. Pernicious anemia, production of antibodies to parietal cells in the stomach. Pemphigus vulgaris, characterized by formation of antibodies against epidermal glycoprotein. Myasthenia gravis, production of antibodies directed against acetylcholine receptors at the motor end plate of a muscle, blocking the receptors and diminishing the muscular response. Third type hypersensitivity reactions. Third type hypersensitivity reactions occur when circulating antibody-antigen complexes precipitate out in a blood vessel or in the downstream tissue. Antibodies are not directed against those particular tissue sites, but they are trapped in their capillary meshwork. In some cases, foreign antigens may adhere to tissues, causing formation of antibody-antigen complexes at those sites. Antigen may be exogenous, for example, medical drugs, bacterial and viral antigens, homologous gamma globulin, antitoxic sera, or endogenous, membrane antigens, DNA of the body cells, and others. Antigen is soluble. It is very important. Third type hypersensitivity occurs in the excess of antigen, leading to formation of small immune complexes that fix complement and are not cleared from the circulation. It involves soluble antigens that are not bound to cell surfaces, as opposed to those in second type hypersensitivity. When these antigens bind antibodies, immune complexes of different sizes form. Large complexes can be cleared by macrophages, but macrophages have difficulty in the disposal of small immune complexes. These immune complexes insert into small blood vessels, joints, and glomeruli, causing symptoms. A small immune complex bound to the sites of deposition, like for example blood vessel wall, are far more capable of interacting with complement. These medium-sized complexes formed in the slight excess of antigen are viewed as being highly pathogenic. Such deposits in tissues often induce an inflammatory response and can cause damage wherever they precipitate. The cause of damage is the result of the action of cleaved complement anaphylotoxins C3A and C5A, which respectively mediate release of granules from mast cells and recruit inflammatory cells into the tissues. The reaction can take hours, days, or even weeks to develop, depending on whether or not there is immunological memory of the precipitating antigen. Immune examples are immune complex glomerulonephritis, systemic lupus erythematosus, Henoch-Schönlein purpura, vasculitis, arthritis. They are commonly associated conditions as a result of type 3 hypersensitivity responses. Skin response to hypersensitivity of this type is referred to as Arthur reaction, which is characterized by local erythema and some induration. This typifies the response to injection of foreign antigen, sufficient to lead to the condition of serum sickness. Type 4 hypersensitivity reactions are caused by some antigens that stimulate primarily T lymphocytes, intracellular bacteria such as TB, syphilis, leprosy, tularemia, fungi, viruses, protozoa, foreign tissues, transplants, natural and synthetic haptens, medical drugs, food dyes, etc. In response to the first exposure to allergen, sensitized T lymphocytes are produced in an organism within 2-3 weeks. Antigen that has entered an organism is captured by macrophage, processed and presented to helper T cells, carrying receptors to this antigen on its surface. T helpers recognize the antigen and with the help of interleukins launch proliferation of effector T killer cells. Besides, T memory cells are also formed that provide a rapid immune response within 24-48 hours in case of repeated exposure to this antigen. T killers may produce a direct cytotoxic effect on the target cells through actions of perforin, which penetrates into the external membrane of the attacked cell and makes it permeable. Inflammation is induced by reactions of lymphocytes and macrophages to the produced antigen plus sensitized lymphocyte complex, and by action of mediators, lymphokines. Examples of diseases with this type of hypersensitivity include granulomatosis diseases such as mycobacteria, fungi, tuberculin skin reactions, transplant rejection, contact dermatitis. Tuberculin reaction. Intracutaneous introduction of tuberculin to sensitized individual causes reddening and edema at the site of injection, with maximal expression in 24 to 48 hours after the introduction. A dense hyperemized papule is formed with necrosis in the center. Necrotized tissue is sometimes rejected, leaving ulcer that heals slowly. Histological examination reveals accumulations of macrophages and lymphocytes. Contact allergic dermatitis runs with damage to skin in result of direct contact with allergens, which usually are synthetic detergents, compounds of chromium, nickel, mercury, dinitrochlorobenzene, food additives, and medical drugs. Low molecular compounds possess properties of haptens, and having joined to their carriers, self-proteins of the body, induce delayed type hypersensitivity reaction. Thank you for attention. Yeah.